So cytomegalovirus, sorry, will take you back to the first year of the medical school. It's a herpes virus, it's a DNA, which basically, the name itself explains the feature it makes. It's enlarging the cells. So it's ballooning the cells, and this is megavirus. And it has this inclusion bodies, which look like the owl eyes. And this is the usual exam questions. What's the virus which give you the owl eyes? So if you have any Hagr question later on, please keep it in your mind. It's a virus that infects any age, and it has been infecting more than 75% of the whole population. And the way of transmission is just fluid, like blood, urine, saliva, and breastfeeding. Important to know the breastfeeding, because when we screen those children, we shouldn't screen their saliva until like 2 hours after breastfeedings. This is the virus which comes among the group of a torch. The C stands for the cytomegalovirus, and it's a very common infection globally, and it's more common than 29 combined metabolic disease that is screened routinely. And it has this risk of sensorineural hearing loss, which varies between 15 to 35%. It's even more than this in some literatures. But the most important things in this virus, it's asymptomatic in 90% of the time. But it has a lot of signs. And this is the signs that we could miss sometimes in those newborns, including the hearing loss. It's a preventable disease, a screenable disease, treatable disease, and hopefully vaccinable disease. What's peculiar things about this virus and hearing loss is it is deceivers, and this is why it's affecting the outcome of hearing loss as well as the cochlear implants, because most of the times it's asymptomatic, it's mainly a sign we see in this virus, and also it's critically important to diagnose it within the first 2 weeks. After 3 weeks, if you get to this virus, it can be a contamination or secondary infection that doesn't really affect the child. And this is the other thing in this one, those children, they could pass the newborn hearing screening, and we could miss this high number and percentage of hearing loss. The other thing, it can be unilateral, it can be partial, it can be fluctuating up and down, it can be a delayed onset hearing loss. And the other thing which make it even more difficult is the virology study for this virus. The IgM and the IgE is not that accurate in making the diagnosis, neither for the mother nor for the child. And also it's opportunistic infection which affect more this low birth weight and premature, and more in the first trimester. It's a preventable disease. It's basically hygiene, which prevent this infection, in particularly for pregnant women. And it's a screenable disease. And you could see here in the graph that it's an easy way to diagnose it either by saliva or urine. But remember, saliva, it should be 2 hours after breastfeeding. Very cost-effective screening, time-effective, and become much easier nowadays because people are aware of the COVID PCR, and this machine is available nowadays not only in the hospital, even in the outpatient clinic. And remember, again, it's more than 29 of combined metabolic and endocrine disorders that have been screened. It's a treatable one. It's more for moderate and severe infection for children less than 6 months. And this used to be treated by ganacyclovir IV for 6 weeks, which was not an interesting for a lot of people to go for it with a lot of side effects. But nowadays there is a valganciclovir, I hope I pronounced it correct, which is given orally for 6 weeks and give you 50% chance of cure. Vaccine. We know the vaccine has a major effect on a lot of disease, and now rubella is becoming a history. Corona, people become familiar with the vaccine as well as the malignancy nowadays being treated by vaccines. So people awareness and interest in this one become an easy things for us to think about it. The problem with the CMV vaccine is being under trial for the last 50 years, and it's still till now it's a phase 2. So I hope with this short introduction about the virus, you will be enjoying the rest of this presentation with the Kari Smilsky from Toronto.
I'll preface this by saying that I too have learned a lot about cytomegalovirus in the last 2 weeks. I work in an adult center, so this was something that was a little bit outside of my wheelhouse. But I really want to acknowledge and thank Dr. Sharon Cushing, who is the head of the Hospital for Sick Children Cochlear Implant Program, which is our pediatric counterpart in Toronto. So she was very generous in sharing a lot of her knowledge with me. So as mentioned, CMV is really quite common. It is everywhere. It's in our daycares, it's in our schools, and this is an example of the seroprevalence in blood samples taken around the world. So these are people just donating blood. In Canada, you can see that we have about a 40 to 50% seroprevalence, but in other places in the world, it's almost 90 or 100%. So it's really common. What it does to the cochlea, this is a mouse model. So the top image is showing the stria vascularis in a normal mouse. And the lower image is actually what happens with cytomegalovirus. So it really destroys the the vascularis, which leaves the cochlea very fragile and really susceptible to not only hearing loss, but also vestibular disorders. So this is a study from Lanzieri from the CDC in 2017, and it shows that kids with congenital CMV actually have an almost four-fold risk of developing sensory neural hearing loss over time. And if we zoom in a little bit, what's really critical here is that you see that almost half of that total risk happens from 3 months to 1 year. So if you think about newborn hearing screening programs, when babies are being screened in the first day or two of life, we're missing a lot of these kids with our screening. So in the province that I practice in Ontario, we're very fortunate that as of July 2019, we've started screening all babies for congenital CMV. And in fact, we screen CMV in a higher frequency than we're actually even screening hearing loss. So since the program's inception, many babies have been born, and 97% of families have consented to have the blood spot screened for CMV. And 607 kids have been identified. Of those, 34 have sensory neural hearing loss at the time of screening, so right from birth. But the other kids that have screened positive have gone into a surveillance program. So what does that look like? Really, it just means that we don't lose these kids to follow-up. Kids who have any symptoms, including hearing loss or maybe without hearing loss, are screened several times in the first year. But even asymptomatic kids are followed really frequently out to 5 years, which is not to say that after 5 years there isn't still an increased risk of developing sensory neural hearing loss. However, it tends to start to track with the same percentages as kids that are negative screened. And so from a financial standpoint, we screen out to 5 years. So the other great thing about practicing in Ontario is the baby's blood spots are stored forever. So at Sick Kids, what they were able to do is have a look at their cochlear implant kids, and they went back and they actually pulled all of their dry blood spots. So over 1,100 kids had their dried blood spots pulled, and 124 of these kids were found to have congenital CMV. And that was really helpful because a lot of these families had no idea why their babies had hearing loss. So it was quite reassuring to be able to let them know what the cause of their hearing loss was. The other really interesting piece of this is of the 124 congenital CMV kids, 114 of those kids had been screened for hearing loss at birth, so it provided a lot of natural history about the progression of the disease. So of the 124 congenital CMV kids, 39% of those had a delayed diagnosis. So what that means is their hearing was screened, but they had normal hearing at birth. So they were not identified until an average of 4.2 years. And knowing that most of the hearing loss is happening between 3 months and a year, these kids really lost out on almost 3 years of good hearing. Of those kids who passed, who had congenital CMV, 50% of those had developed some degree of sensory neural hearing loss by 3.5 years. And by 7 years, 70% of these kids had hearing loss in at least 1 ear. And it's really heterogeneous. So if you look at the type of hearing loss these kids develop, it's really all over the map. But I think what's most striking is 68% of these kids have unilateral hearing loss. The Sick Kids experience in Toronto is congenital CMV is the most prevalent etiology for kids who are implanted with single-sided deafness. And if you look at these numbers, you can see that 4 of these kids actually were missed on the newborn infant screening program. So it speaks to how critical that screening program is. I think it also really speaks to the counseling that we do. So at the Sick Kids Experience, a third of families with babies with single-sided deafness choose to move forward with CI, but of those kids with confirmed congenital CMV, 81% actually will move to an implant. And that's really important because if we look at the progression of the disease, 65% of those unilateral kids develop bilateral hearing loss. The other benefit of an early screening program is just we know that the earlier, the better. And kids who test positive for congenital CMV actually get implanted about 8 months sooner. They have access to MRI scans, ABR, and ENT consults much sooner. So I'll finish up just by concluding that we know that it's a very, very common infection. It's the most common implantable cause of SSD for these babies. There is a role for antivirals if they're identified early. Dr. Cushing would be upset with me if I didn't mention that there's also a very significant risk to the vestibular system, so there's probably a good benefit in adding some vestibular screening to what we do with these babies. And we know that the earlier the better, so the best therapy for these kids is really to detect them early, provide them rehabilitation early, and that can only be done with universal screening.
Thank you. Thank you.
Thank you. So I'm actually going to...
Yeah. Abdulrahman.
Thanks, Kari, for this wonderful things about this virus. And I would like just to re-emphasize the importance of awareness. And you could see here in this slide, it shows the awareness of people in the United States about this virus, comparing the HIV percentage and the awareness of 98, and in the opposite is the
CMV.
Percentage of CMV and the awareness. Imagine 14% only the awareness of women of this virus, which, by the way, is better than the things in Saudi Arabia. The awareness of Saudi Arabia of people, professionals in the medical service is 15%. And I think I'm among those 0.2%. And this is a paper we're submitting it for publication soon, which is a congenital cytomegalovirus screening, a comprehensive review. I'm sure one of you going to review it, so please accept it immediately. Thank you. Remember, the outcome of CI is diverse in those cases, and it shows that in all the study, the control are better than the CMV cases, except those who develop hearing loss after 5 years, and those asymptomatic cytomegalovirus is better than those treated symptomatic cytomegalovirus, who's better than non-treated cytomegalovirus, but there is no contraindication for cochlear implant for all the patients with CMV virus. And the other thing, the MRI finding, whatever it shows, it's not really correlated to the speech outcomes. So please don't be surprised with whatever MRI you see with those cases. Still, they will benefit from cochlear implant. Thank you.
Thank you so much, Abdulrahman. Kari?